Um, very good afternoon, everyone. After a long time, we are all getting together for a very important CME, which has got recently updated. We all know that endometrial cancer is becoming quite common. It is sixth most common cancer in the world, and maybe it will take over cervix very soon because we have a lot of screening methods for cervical cancer, and other lifestyle modifications are increasing the load of endometrial cancer. Earlier, we hardly used to see. Nowadays, almost every week, at least 2 or 3 cases we are doing. It's becoming quite common, more than cervical cancer in the early stage. Of course, we do still have a lot of cancers of cervix in the late stages, but early cervical cancers, because of a good screening and now slowly picking up, HPV vaccination is also picking up. I'm sure we almost, like WHO says, will eliminate, though we may not eradicate. So why have we thought of this topic is because sorry. Okay, because recently there have been a lot of advances in the diagnosis and management of endometrial cancers. More so, we all know that there has been a recent change in the staging system of endometrial cancer, which is FIGO 2023. It is quite extensive, I would say, but a lot of new things have added. I'm sure slowly over a period of time, we'll get used to that staging, though it is very, very extensive. It also helps us in treating the patient. Okay, a lot of molecular basis has been added. So for the CME, as we all know, we'll start off with our junior resident, Dr. Indraneil, who's a 5th sem postgraduate, who's going to tell us in detail about why this change in endometrial cancer. I hope, Indraneil, you'll cover that. And what are the changes? He'll make us understand in a very simple manner, I hope. After that, we have of course, Core Diagnostic is the person who is supporting us, who's the company who's supporting us, and they are the ones who have come out with all the molecular investigations which we would be doing for endometrial cancer. For that, we have Ms. Aditi Agarwal and her team who are here. Then we have our own Dr. Prashant Ganeshan, who's a professor and medical oncologist, who will be talking on therapeutic implications. And before that, we have a very, very important person, Dr. Francis. We'll talk more about him. He's a radiation oncologist, but unfortunately, he's coming online. I think he will make us to understand very simply how to manage endometrial cancers. So with this, I hand over the mic to Indraneil to start off his talk on the staging. And I'm very happy to see people in large numbers, not just from Department of Obs-Gynae, across all the institutes, but also we have people from pathology, radiation oncology, medical oncology, from across the place. I'm very happy to see such numbers, and I hope this, I've been never seen in OGSP. Whatever is the reason, we are very glad, and I hope this continues. These things, I mean, I always tell, these small focus programs are much better than attending big conferences. But yes, it's very important because the topic is very, very focused. I know it is a bit too much sometimes, but this is the need of an hour, and we need to know about endometrial cancer. Thank you, and over to you, Indraneil. Before I forget, one more announcement. We have a register which is passing across. Please sign the register. So are we giving any CME points to one? But yeah, we'll get an e-certificate for this. So please sign your names in it. Okay, thank you. Don't forget, some of you have already signed, but others will not. Yeah, otherwise you won't get the e-certificate. Please write your name. Thank you.
Good afternoon, everyone. I'm Indranil Dash, final year PG from JIPMER Obs and Gynae department. I'll try to simplify the 2020 staging of endometrial cancer staging. This is the 2009 staging that we all knew since our UG days. We came to post-graduation reading this one only. After I came here in post-graduation, then we came to know there is something called risk stratification. Am I audible there at last? Hello, am I audible now? After coming to PG, we came to know there is ESGO to ESP guideline, which is risk stratified endometrial cancer. Somehow I managed to read that. Now, after coming to final year, I saw that there is something new thing that FIGO has given 2023 classification, staging of endometrial cancer. So it was a bit difficult for me to understand, but I have done a method to understand that. Now I'll share with you. This is mainly for my fellow postgraduates. So let's see. What is new there? We know there are many prognostic factors for the endometrial cancers. The 2009 staging has incorporated the myometrial invasion and the cervical stromal invasion in the staging. The 2023 staging has involved some more. They have involved the histological types, the grade, the lymphovascular space invasion status. Previous staging had serosal involvement. In this staging, in 2023, they have included subserosal involvement also. Adnexal involvement, that is involvement of the ovaries and the fallopian tubes. Now here, they have considered it in two stages. Involvement of the ovary is there in 1A3 and 3A1. We'll come to that later. But in two places, we have that and with some minor differences between these two stages. Now, lymph node involvement, we know it was previously at 3C1, 3C2. It was very easy, 3C1 pelvic, 3C2 paraortic. Now, they have kept the same thing, but italic 1 and italic 2, they have added to each. They have made it micrometastasis and macrometastasis. We'll come to what these things are. And also peritoneal involvement, abdominal, extrapelvic peritoneal involvement is also been considered in this staging. Now, I'd like to simplify the staging by using an analogy of a school where some guys are there. It's a boys' school with some good boys and bad boys who want to escape the school. So before that, let's consider some general rules. The general rules are, there is a 336. What the first 3 stands for, it says that all 3. We know there are 4 groups, A, B, C, D. It 4 stages, each has 3 subcategories. So we have 1 ABC, 2 ABC, 3 ABC, 4 ABC. So all 3. Next one is 1A has 3. So after all 3, 1A3. In 1A, we have 1A1, 1A2, and 1A3. And stage 336, the last 6 is, the stage 3 has total 6 subgroups. So each 3A, 3B, 3C has 3A1, 2, 3B1, 3B2, and 3C1 and C2. C1 and 2 has italic 1 and italic 2 that I told previously. Now, who are the good boys and bad boys? Now, as I previously mentioned, they have included the histological type and the histological grade also in this staging. The endometrial type of endometrial cancer, they have used the binary grading system for that, low grade and high grade WHO grading system. In the low grade, they're grade 1 and grade 2, involving the less than 5%, 6 to 50% of the solid component are there that comes under the non-aggressive variety. So this is the only good boy we have. And the rest of the people are high grade endometrioid, serous carcinoma, clear cell carcinoma, mucinous variety, unclassified variety, carcinosarcoma, and the gastrointestinal type. They come as the bad boys. So if we write the general skeleton first like this and try to fill in the blanks, then it will be easy for us to remember. Now in this image, okay, I'll just tell this one. Okay, now let's see the image. Now, what is the school? What is the classroom here? This red thing, if you can see, this is the endometrium. So this is the classroom. The students initially will sit in the class. After that only, they will decide to escape from the class. So how can they escape? They will first come to the door to see if anyone is outside, or then they can escape or not. So when they are coming to the doorstep of the classroom, let's consider that to be less than 50% myometrial invasion. And when they're outside the class and the corridor, consider it to be more than 50% myometrial invasion. This ovary, we'll consider it to be the canteen of the school. We'll come to it later. Now, once they're in the corridor, after that, what they will do? They will try to go to the next class. The next class is here, the cervix. Cervix is the next class. After they have gone to the next class and explored everywhere on the same floor, they will try to go out. While going out, they will think, how can they go out? They can go out by three means. Either they can walk, they can use a cycle, or they can use a bike. Now, what is the cycle? Cycle is the most common, what is walking method? That is the most common route of spread. That is direct spread. What is cycle? Cycle is lymphovascular space invasion or lymphatic spread. And what is bike? That is our hematogenous spread. Now, once they have come, gone across the next class, they will try to escape from the school. That is, they will come to the school gate. The school gate for us is this green line, which is the serosa. Serosal involvement was there in the previous staging. In this staging, they have included subserosal involvement also. Once they escape the serosa, they will try to go to the next places. What are the next places? They can come to the immediate next place, which is the vagina, or they can come subsequently to the parametrium, and subsequently they can come to the pelvic peritoneum. Once they have explored all these areas, they will go to the lymph nodes, and then they will go to the abdominal peritoneum or abdominal lymph nodes, and by the pike, they will go to the liver or spleen or any solid organs. Now let's come. We all know in school, we have two sections, C section. We have A section, B section, C section. We know C section was notorious for the bad boys. So in first stage 1 and stage 2, this 1C and 2C, these two parts will keep for the aggressive variety. All our bad boys will come here. Next come are all others, 1A, 1B, 2A, 2B, all other things will be for the good boys. Now initially, what will the good boy do? The good boy will sit in the class. So the 1A1 is good boy sitting in the class. That is our non-aggressive fellow who is sitting in the class. In the terms of the staging, it will be non-aggressive variety, which is in the confined to the endometrium or in the polyp. Next, what it will do? It will try to escape. How it will try to escape? It will go to the doorstep, as I told previously. That is less than 50% myometrial involvement. That is 1A2. But at the same time, he is not thinking about going out of the school. So the LVSI is not coming there. Now coming to 1A3. 1A3 is a special variety. We told previously that 1A3, if we read it from opposite side, it comes 3A1. Nothing else will come like this. Like if you come from the opposite end, it will give a new stage there. So 1A3 and 3A1, these are the places where ovarian involvement will come. But there is obviously some difference why ovarian involvement is there in stage 1 also and stage 3 also. 4 criteria are there that has to be fulfilled. Number 1, it has to be a low grade both in the endometrium and the ovary. No other distant metastasis, only single ovarian involvement should be there. So 1A3, we have uterus and the ovarian involvement. We can remember it as similar looking good boys sitting in the canteen also and the classroom also, but they're not doing anything. Next, once they have gone to the doorstep, they will now go out of the class in the corridor. That is more than 50% of the myometrial involvement. That is coming in the 1B. If we remember our old staging, there also 1B only was there. Now coming to stage 2. Before going to stage 2, let's see what 1C is there. 1C is our bad boys. Bad boys sitting in the class, that is only a very headache for the teachers. So even if they're sitting in the class limited to the endometrium, they will be 1C. Now come to stage 2. Stage 2, it says there is invasion of the cervical stroma without extrauterine spread, or there is substantial LVSI, or there is aggressive with myometrial, aggressive variety with myometrial invasion. Now, what if we summarize the stage 1, our fellows in stage 1B has gone in the corridor. Now, what the next they will go? They will do to the next classroom. The next classroom, as I told previously, is the cervix. So in 2A, we have cervical stromal invasion. Next one is there 2B. When after exploding, they're thinking of going out. And at this place only, they're thinking about going out of the school with cycle. So LVSI has come. So non-aggressive variety with any myometrial invasion, when there is LVSI positivity, that will come in stage 2B. So what 2C, the aggressive bad boys. Bad boys, anytime they're at the doorstep or outside anywhere, it will come in 2C. So they're sitting in the class is 1C. Anytime they're out, it's 2C. Now, this extensive and substantial LVSI, what they have defined is more than equal 5 vessel involvement. Now, coming to the next one, stage 3. 3A, as we told, it's come the 3, it's the last, in the rule of 3, the 6, 3, 3, 6. Each will have 2 subgroups. 3A will have 1 and 2. Now, let's see what is 3A1. One is in 1A3, we have told ovarian involvement of was there. So if we read it from the back side, it will come 3A1. So in 3A1, along with the ovarian involvement, there is fallopian tube is also there. And also all the 4 features that we told, those things will not be there. Like in this situation, the grade may be high. There may be some other metastasis also, and there can be bilateral ovarian involvement as well. Now, what is next? They have gone till the next class. After that, they will come to the school gate. What is the school gate? It was the serosa. So serosal involvement comes in 3A2. Now coming to 3B. What is 3B? After going to the school gate, they will roam in the near vicinity. What was the near vicinity in our analogy? It was the vagina and the parametrium. So vaginal and parametrial involvement will come in 3B1. 3B2, they will be in the near vicinity only, but some far. What is the far? That is the pelvic peritoneum. And 3C is our well-known 3C1 and 2, pelvic and para-aortic. Here, each 3C1 and 3C2, they have given italic 1 and italic 2 as micrometastasis and macrometastasis. We'll define what is micrometastasis and macrometastasis later. Now, coming to stage 4. In stage 4, there is direct spread also with bike they are going on. Initially, if they're going by walking after coming out of the school, initially they were roaming, around the school in 3B. They involve the vagina and parametrium and the pelvic peritoneum. After that, they are going to the neighbor's home also. Who are the neighbors beside the uterus and cervix? You have the bladder and you have the intestinal. So their mucosal involvement comes in 4A. In 4B, they're going up. Extra pelvic peritoneum they have gone. And the last 4C, where with cycle they will go too far, and also with the bike also they will go too far. There comes our solid organ involvement, lymph node, abdominal lymph node involvement above the renal vessels, and extra abdomen also. So till here, the staging is done. Now we'll see what each minute thing matters. What is low grade and high grade? Low grade, as I told, it is grade 1 and grade 2. It includes involving less than 50% and 6 to 50% of the solid components. And high grade is more than 50%, is grade 3. Now, they have mentioned that if the nuclear atypia is excessive for the grade, it will raise the grade in grade 1 and grade 2 tumor. For the presence of unusual nuclear atypia in an architecturally low-grade tumor, it should prompt the evaluation of P53, and we should consider for the serous carcinoma. Now, coming to ovarian involvement, this one we have already mentioned. The criteria, what will define 1A3, which will differentiate 1A3 and 3A1. It will be 1A3 if there is less than 50% myometrial invasion or no myometrial invasion. If there is absence of extensive or substantial LVSI, if there is absence of other metastasis, and the ovarian tumor involvement is unilateral without capsular invasion or rupture. Now coming to the micrometastasis and macrometastasis. Micrometastasis is when there is less than 0.2 millimeter. And what is macrometastasis? Macrometastasis is more than 2 millimeter in size. In micrometastasis, many things are also there, like more than 200 cell or an isolated tumor cells of more than 0.2 millimeter and less than equal 200 cells. Now coming to examples, hope I was able to make people understand something. Okay, so in summary, okay. Okay, so here, 1A, we can remember our rules, 336. The first 3 was, can anyone tell what are the first 3? Okay, I will tell all 3. Each 4 stage will have 3 subdivision, A, B, and C. The second 3 was 1A has 3. So in 1A, we have given 1A1, 1A2, and 1A3. And the 6 was what? 3 has total 6. So what was 1A? Where does our this bad fellows are coming? In which 2 stages our bad fellows are coming? 1C and 2C. The C section, notorious boys are there only. So what happening in 1A1? Here are good fellows are sitting in the classroom only. So non-aggressive histological type limited to polyp or endometrium. After that, what are they doing? They're going to the doorstep. They're going to the door to see if anyone is there or they can escape or not. So less than 50% myometrial invasion will come in 1A2. Next, what is 1A3? 1A3, we know 1A3 and 3A1 is involvement of ovary. So ovary with all those 4 points, which will make them in stage 1A3 will come here. What was 1B? 1B was they are going to the corridor. There was a more than 50% myometrial invasion with the non-aggressive histological types. What was 1C? In C section, we have our bad fellows. So bad fellows even sitting in the class. So limited to the endometrium. What was 2A? After going to the corridor, where they will go? To the next class. So next class was cervix. So cervical and stromal involvement is 2A. What was 2B? After going there from there, what? There they will think of using cycle to go out. So what was that? Non-aggressive type with LVSI. They're just thinking of cycle. They have not used the cycle yet. Next, what was 2C? Again, our notorious fellows. Notorious fellows, anytime they're thinking of going out, it will come under 2C. Now coming to stage 3. Stage 3A, 3A1, as we know 1A3 and 3A1, 2 fellows. 3A1 was our ovarian involvement. Along with that, 1 fellow was also there. Fallopian tube. Next, and which is not meeting the criteria of 1A3. What was 3A2? 3A2 was there in the door. They're in the school gate. School gate was serosa. So serosa will come in 3A2. After that, what they will go? Once they go out of the school, they will roam near the vicinity of the school. Very near. What were the structures, anatomical structures very near to the schools? Vagina and parametrium. So that will be 3B1. And apart from vaginal parametrium, they will go, what they will found? Peritoneum. Which peritoneum? Pelvic peritoneum. So that will be 3B. And 3C, 1 and 2 are unknown things, pelvic and paraortic lymph node. 4A, after that, they have gone some more up. Where they have gone? Bladder. Neighbor's house they have gone. 4B, they have gone up to the, okay. 4C, they have gone to the lymph nodes above the renal vessels, extra-abdominal lymph nodes or solid organ involvement. Now we'll go and see some examples. All these are the cases which we have operated in Jipmer. 56-year-old para 2 living 2 who presented with postmenopausal bleeding. Imaging showed there is a thickety of 3 centimeters. FC showed there is a grade 2 endometrial adenocarcinoma. So patient was planned for surgery. She underwent TLH, BSO and pelvic lymph node dissection. The final histopath report is there. It shows grade 2 endometrial adenocarcinoma, less than 50% myometrial invasion. There is no LVSI, no cervical stromal involvement and no nodal involvement. So is it? So the final histopath report, are they good boys or bad boys? Good boys. Where are they? Less than 50% myometrial invasion. Are they in the corridor or at the door? At the door. So at the door. And have they thought of cycle? They haven't thought of cycle. And they have not gone anywhere. So the stage will be at the door. 1A, 2. Okay. Coming to the next example. Here we have a 41-year-old who is abortion 1. She's premenopausal. She came with an acute AUB of 3 months. She got an outside scan done, which showed thick irregular endometrium, and there is 10 × 7 millimeter of hyperechoic mass in the cavity. So EB was done, which showed grade 1 endometrial adenocarcinoma. She underwent extrafascial hysterectomy with pelvic lymph node dissection. Histopathology shows grade 1 endometrial adenocarcinoma with more than 50% myometrial invasion, no LVSI, cervical stromal invasion, and nodal involvement. Are they good boys or bad boys? Good boys. More than 50% myometrial invasion means what? Where are they? In the corridor. In the corridor, what will be the stage? 1B. Okay. Next example, 45-year-old para 1 living on ectopic 1. She's diabetic. She's a known case of CA breast and tamoxifen. She came with acute uterine bleeding. Ultrasound shows. Sorry. Acute AUB. I plan to write. Okay, sorry. USG showing a thick ET of 2.7 centimeters. The FC was showing grade 1 endometrioid adenocarcinoma. She underwent extrafascial hysterectomy, bilateral salpingo-oophorectomy, and pelvic lymph node dissection. In this case, histopath was showing grade 1 endometrioid adenocarcinoma, less than 50% myoinvasion. LVSI was positive, but there was no cervical stromal invasion and lymphatic spread. So are they good boys or bad boys? Good boys. Less than 50% myoinvasion. Where are they? In the corridor or in the doorstep? Where are they? In the doorstep or not? They are at the doorstep. And are they thinking of cycle? If they're thinking of cycle, where they will go? 2B. Last example, 70-year-old para 2 living 2. She's postmenopausal. She came with white discharge PV and postmenopausal beat for 1 year. Ultrasound shows 6 × 3.4 centimeter growth in the cavity with more than 50% myometrial invasion. EB was showing grade 2 endometrioid adenocarcinoma. She underwent extrafascial hysterectomy, bilateral salpingo-oophorectomy, and retroperitoneal lymph node dissection. Both pelvic and paraortic was done. Grade 3 endometrioid adenocarcinoma was in final HP with more than 50% myometrial invasion. LVSI was positive. There was no cervical stromal invasion. parametrium was free, but there was para-aortic lymph node involvement. I think this is the easiest. If para-aortic comes, the staging will be 3C2. Thank you.
One round of applause for Indranjit. We try to make one difficult staging very simple. Stay there. Questions will come. Anybody has any questions? So basically, what you have to understand is his analogy of good boys, bad boys is very nice. Most of the aggressive tumors will be either 1C or 2C. But please remember, the moment they go out of the uterus, they're not going to be there. Right? For example, it is a serious carcinoma which is spread to parametrium. So don't think of putting them in 1C or 2C, because they have left the uterus. And obviously, for the management purpose, what's important for us is that uterine confined disease is the one where we have to really worry. Because once it goes beyond the uterus, that is stage 3 onwards, treatment is going to be chemotherapy plus it. Okay. The need for adjuvant therapy arises mainly for us when it is confined to the uterus. Okay, that is why we need to so many subdivisions and how we can avoid giving unnecessary adjuvant therapy. You will learn throughout the course of the CME, how else we can avoid giving unnecessary adjuvant therapy. So lots of things are still coming. So any questions about staging? Do you think the staging is perfect? Actually, when it came up, immediately when we saw, we thought, oh my God, what is this? Because the simplest gynecological cancer staging was endometrium for us, right? When compared to anything else. And suddenly we saw that, it's become so extensive, right? So, but that's when we started, reading it and discussing it in the department and our cancer clinic and all, we realized that they have tried to fill almost all the gaps. Because we used to have cases. I had a case of serous carcinoma of endometrium with pouchy Douglas deposits. Where did we put them? According to the old staging, there was nowhere we could put them. We had a patient with peritoneal deposits high up in the paracolic gutter. Okay, we didn't know where to put them, right? Because they were, even though they behaved like ovarian tumors, all these aggressive types, they were still staged as endometrial cancer, right? So they have filled up a lot of gaps. There is only one deficiency. Can anybody tell me what exactly? It's not worded. We assume probably it will come in that stage. In spite of, I think it is just overlooked. So that's what I think. What do you think is missing in this? Cervical stroma? Very good. Okay, aggressive tumor, cervical stroma. Okay, because the 2C is aggressive tumors with any biometric invasion. They have not clearly mentioned that it is also cervical involved, stromal invasion. Okay, that's the only thing we may still have a query, but we have decided to put it in 2C. If it is aggressive tumor and cervical stromal invasion, probably it's an overlooked thing. That's all, because it's still confined to the uterus, right? So we will put it in 2C. That's all. Anything else? Anybody wants to add anything, madam? We'll move on to the next talk. One more big round of applause. So molecular profiling of endometrial cancer is not just the future, but it is an integral part of the present day management of endometrial cancer. To share more on this topic, we have our next speaker, Ms. Aditi Agarwal, molecular scientist, NGS analysis and reporting lead, core diagnostics. Over to you, madam.
Good afternoon, everyone. Am I audible till the last? Yeah, so this is the first cancer where I'll say the role of molecular department, where in the classification, in the prognostication in endometrial carcinomas, it's highly important. No other cancer involves molecular at the first stage for the prognostication and the risk stratification. So the therapies which we were talking about in the last presentation, the adjuvant therapy, chemotherapy, radiotherapy. So molecular classification has a role to play in these decisions also, therapeutic as well as prognostic. So this is the basic slide. Endometrial carcinoma is the most common gynecological cancer. Uterine cancer is the most common, and 90% accounts for the endometrial cancer, and rising incidence over years. So that's why a lot of research, a lot of studies has already happened, and now we are in the stage where a lot of information is there for the therapeutic decisions and for the risk stratification, for the prognostic decisions. Yeah.
Are you people able to see from behind? Can you?
Yeah.
It is PowerPoint, but she's not always.
It's PDF. It's PDF. Yeah. It's still less.
It's still less
And
because people are there. All of you are able to see?
one second. It's okay. It's fine. Click. I think now it's fine. Yeah, so as I mentioned, it's treatment disease molecular classification is now the part of risk stratification, prognostication, and therapeutic decisions. Overall, for endometrial, first is risk prediction algorithms. We have two different algorithms, and then stratification into low, intermediate, high, intermediate, as we discussed just before the presentation, on the basis of the clinical presentation, age, comorbidities, fertility, pathological, FIGO staging, tumor type, grade, LVSI, and the last but not the least, molecular classification. So it's the development of a molecular classification system will not only improve routine pathological practice, but also has the potential to enhance early diagnostic approaches. And the three basic classification, the first one is TCGA, and the next two are the studies which actually, okay. So next, this PORTEX study and the PROMISE study, they actually supported the TCGA classification system. This is the major slide. So apart from the FIGO staging, so there are three major molecular markers which we have to include in the classification in the risk stratification. The first one is POL-E gene. The second is MMR, both by IHC and by your molecular Sanger or NGS. I will discuss it later also. And the third one is TP53 gene. And when all the three genes are missing, so we'll classify that no specific molecular profile, NSMP. So that is the fourth one. So, but initially what TCGA classified as is when poly mutation is there, so it's ultra mutated. The first classification, if you see on the left-hand side, is when poly is mutated, it's ultra mutated. Second one is when your tumor is MMR deficient, or it's MSI unstable or MSI high. So there are three terms in the reports you will get: MMRD in the MMR deficient tumors, MSI high, or it's like your MSI unstable. So then that class, the class is hypermutated. I have listed all other genes also, but these are the major genes. Third is your copy number low, which is your no specific molecular profile, NSMP, where none of the gene is positive. The poly, TP53, it's like your in the breast cancer when your ERPR, HER2, all three are negative. Same way here, poly also negative. Yeah.
You don't have to.
Yeah.
So MSI, MMR, everything.
Yeah, that I will come later on. Yeah. So yeah, copy number low is when all three are negative. So then the copy number low, and under these category, other mutations are also there that we will come later on. And the copy number high, it's the TP53 mutated class. When your TP53 mutation is there, your copy number high class is there. So this is the basic TCGA classification system. So POL-E, the first one is POL-E, ultra mutated, and POL-E muted. Prognosis is always good, favorable for this class, and mutation load is high. Your TMB, tumor mutation burden, or your MSI testing. So tumor mutation burden, TMB, will always be high in this. Then in your MMR, mismatch repair deficient, I will come later on also. Its MMR is mismatch repair deficient class. Your MMR genes, one or all of the MMR genes are defective. Overall, the pathway is defective. The cell is not able to repair the mismatches during replication. So we classify that tumor as MMRD, MMR deficient tumor. The prognosis is intermediate and the mutation load is high. The third category is when your TP53 mutation is there. They will also call it as TP53 abnormal class or class with high copy number. So there are different terminologies, but ultimately this is four major classes are, first is poly, you can call it as ultra mutated also, poly, good prognosis, high load of mutations. Next is your MMR deficient. Third is your TP53 abnormal class, where TP53 mutation is there. That means TP53 is not working as a gene. TP53 is a tumor suppressor gene, so there is a loss of TP53 functionality in that particular tumor. The prognosis is always poor, unfavorable, and the mutation load is low. And the fourth class is no specific molecular profile, NSMP. Other classifications, they call it as unclassifiable, also unclassifiable or NSMP. And absence of all three major markers, prognosis is always intermediate and mutation load is low. So after TCGA classification, basically two studies came up which actually supported this TCGA classification. First one is POTEC study. So the POTEC study defined these studies basically further, they simplify the classification system of TCGA for the pathologist and the labs. So this POTEC study defined four prognostic subgroups. First is TP53 mutant, TP53 abnormal also you can say, or the group with high copy number. The second one is microsatellite instability. So these are your MMR deficient, MMRD, microsatellite instability, or microsatellite unstable. So all different terminologies for only one group. Then is your poly mutant, which was in the TCGA, what it was? Ultra mutated. So poly mutant, and the fourth one is again NSMP, no specific molecular profiling. And these studies, they have actually given us the way also how do you test. They have defined that. So testing TP53 expression and TP53 mutation as well. So TP53 expression by IHC and TP53 mutation by your molecular Sanger technique or NGS technique. Then your MMR gene expression by IHC, and then Sanger sequencing for poly hotspot mutations. So the TP53 group, as TCGA also defined, the TP53 group exhibited the unfavorable prognosis compared to all other three groups, while the poly mutant group showed the most favorable prognosis. So prognostication was same between all the classifications. Your TCGA also said the same thing. And these two studies, POTEC study and PROMIS study, they supported the prognostication and the risk stratification of TCGA. So along with your FIGO grading, you have to have these molecular markers testing done. So this is the basic classification, is whether it's poly mutant, then it's the different class, then poly wild type, then poly wild type will go for MMR testing, MMR deficient, MMR proficient. So MMR proficient means your MMR is working inside the tumor. It's the normal. And MMRD is when MMR genes, either their expression is lost or their transcription is lost. And then if MMR proficient, they will go for TP53 testing, but nowadays at one go. So that's why the companies, the molecular labs, they are offering one confined endometrial panel, where at one go, we will check all these three genes. We will check TP53 also, poly also, and your all the MMR related genes also, both by IHC and your molecular type. Then your PROMIS study. So this study also, it further simplifies the classification system and the prognostication part. It also supported the TCGA prognostication that poly has the most favorable prognosis and TP53 showed the worst prognosis. So again, it's MMR deficient, MMR proficient, then they'll go for poly testing, poly positive, poly mutation negative, then they'll go for TP53. And if any of the alteration is not there, so then it is no specific molecular profile, NSMP, or unclassifiable. And this is basically the crux of all three, TCGA also, POTEC also, and your PROMIS study also. So all three classifies into three, poly, TP53, and your MMRD. Paul E is almost the percentage is same in all the studies. Then is your copy number low is when your TP53 is normal. Copy number high is when your TP53 is abnormal. And they have classified further also. They have given the incidence and they have given your risk stratification also. That favorable is your on the left hand side, favorable is Paul E mutated, unfavorable is TP53, and your MMR deficient is intermediate. And they further, apart from these three genes, they further went ahead and they studied further molecular markers also, especially CTNNB1. So if you see the first class, so Paul E was mutated, but MMR was intact. The tumor was not deficient for MMR, and also CTNNB1, your beta-catenin gene, was also not mutated. The unfavorable, if I see, TP53 mutation was there, MMR was intact. And if the intermediate, we will see it's an MMR deficient tumor with or without TP53, but beta-catenin was mutated. So poly, TP53 and MMR, these are the like three you can't skip, like for molecular classification, risk stratification. But apart from these three, further also in studies, beta-catenin, PIK3CA pathway, lot many markers, they came into picture now. So this is the basically the classification. The crux is your endometrial cancer. First is your histology classification. The major pathway alterations are PIK3CA, KRAS, and EGFR pathway. Genomic subtypes, your Paul E, MSI is MMR deficient, copy number low, and copy number high is your TP53 mutated. And mutation load also ultra mutated. Paul, you can remember like this, poly is always ultra mutated, lot of mutations are there. Then is your MMR deficient, hyper mutated, again lot of mutations. But for TP53, copy number is high, but not lot of mutations. The number of mutation is always low. So the molecular subtype cannot be reliably inferred from clinical pathological factors. The majority, but not all, serous ECs are P53 abnormal, and low-grade endometrial carcinomas are NSMPs respectively, whereas high-grade endometrial carcinoma can represent any of the four molecular subtypes, adding to the importance of implementing molecular classification. So you need to do molecular diagnostics on the basis of clinical pathological or histopathological parameters. You cannot say whether it will be TP53 mutated or not. So molecular subtypes also have predictive importance based on the preliminary data, which require independent confirmation. Patients with Paul E mutant EC could be spared the adverse effect of adjuvant therapy, whereas patients with MMR deficient benefit from radiotherapy but not chemotherapy, and while patients with TP53 stand to benefit from chemotherapy. So this is like, now the studies have established this as along with your FIGO grading. These three markers will decide whether the patient will go for adjuvant therapy, will benefit from adjuvant therapy or not, or will benefit from chemotherapy or radiotherapy. So this molecular classification system will add to your decisions, both therapeutic and prognostic. So this is the rainbow umbrella trial, where you can see TP53 abnormal will go for chemotherapy and chemotherapy plus DDR targeting agents. Your MMR deficient therapies, they will not be benefit for your from your chemotherapy. So radiotherapy plus PDL1 inhibitor, because they are TMB, mutation load is high. So that's why your immune checkpoint inhibitors. Then your no specific molecular profile, because there is no mutation, so all therapies are relevant here to try out. And then is poly mutation, no adjuvant treatment. So this is the final crux of the rainbow trial, and you, after the molecular classification, you can consider this to decide which therapy to go on for the patient. And again, this is the latest further subgrouping of the risk stratification for molecular classification unknown and molecular classification known. So further these staging, which we just talk about, 1A, 1B, 1C, 2A, 2B, 2C. The left side is when the molecular classification is unknown. The right side is when the molecular classification is known. So accordingly, they have classified into different risk subgroups. So these are the, I have got a request that we need to like specifically discuss about the panels. So what I advise is we have to go for a confined panel where TP53, poly and MMR deficient, all three we should test. But different panels are available. Like the first panel is TP53 and poly sequencing. So this is an NGS based panel where the complete TP53 gene and the complete poly gene gets sequenced. Although if you different companies, they offer poly specific mutation testing from exon 9 to exon 14. But here nowadays, because TP53 is a tumor suppressor gene, we need to check the entire gene. So that's why TP53 by NGS and also poly, again, it's a tumor suppressor gene. So we need to check the entire, we need to scan the entire gene by NGS. And the next panel is TP53 and poly sequencing plus your mismatch repair protein panel. So this is MMR testing by IHC, in which we test 4 different genes. You know, MMR genes. So all the 4 genes, we check the expression by IHC. And then we say, I have the reports also, then we say whether it's MMR deficient or MMR proficient. Then we have different, like only poly, if you want to check only poly, if you want to check only TP53, if you want to check only MMR, so those panels are also there. But now every lab, they have developed a confined panel where all the 3 markers we are checking. Yeah. So endometrial panel, we have 2 panels, endometrial panel advanced and endometrial panel basic. So endometrial panel, if you see, advanced is like MSI, poly, and Sanger TP53. The technologies is Sanger sequencing for TP53. Poly by PCR. As I mentioned, exon 9 to exon 14 of poly. So that's why poly by PCR, and your MSI is MMR by IHC also and MSI by PCR also. So you will get both the reports, whether your tumor is MMR deficient or not, or is proficient, or whether the microsatellite is stable or unstable. And the endometrial panel basic is only Sanger sequencing and IHC. Here you will not get MSI report, whether your tumor is MSI stable or unstable. So this is the report where TP53 and poly recently from your department only we got that we need the status on the first page only. So these TP53 and poly both genes we are checking by NGS and we are listing out the mutation. So here on the first page you will get if the TP53, if any mutation is there, we'll write positive and clinically relevant variant identified. And poly is negative, no clinically relevant variant identified. And in the variant summary, you will get the exact details of the variant. Like in TP53, which exon is mutated and with how much VAF, variant allele. So this is the NGS report. And this is the poly gene specific testing on Sanger.
What happened? Maybe someone is
now it's fine. So this is the different test, Dr. Veena. This is poly only for exon 9 to 14 by Sanger. So we are checking only from exon 9 to exon 14 by Sanger sequencing, and we are listing out the mutation, whether it's detected or not detected. But the first test that I showed you where we are giving the exact details, this is by NGS, next generation sequencing. So TP53 and poly. So I will say now it's like TP53 and poly by NGS, MMR by IHC, and MSI by PCR. So this is the final test which every lab is doing and which will give you the like final answer without any loopholes. So TP53 and poly by NGS. Yeah. Both are same, ma'am. No, both are same. So when you talk about gene, that is TP53 gene. So when you talk about protein, so it's P53.
Yeah, but if you have done
Yeah.
immunohistochemistry for P53.
Yeah.
Is it equivalent to doing P53?
No. Actually, what happens is when you are checking protein expression, you are checking by IHC. IHC will tell you whether the protein is there or not, but it will not account for the mutations that are happening at the genetic level. So genetic, yeah, TP53 mutation by NGS.
One more doubt, I know how
Yeah.
relevant it is. This TP53 is positive.
Yes.
Does it mean, see, we have this Lynch and all, right? Then those cases also. will be
That is for MMR.
for MMR.
MMR, not for TP53 and poly, for MMR. So TP53 is your gene because the mutations can occur at both the levels, at your promoter level also, when your gene is getting transcribed for like more copy numbers, and also when the gene is functioning in a pathway. So mutations can happen there also. So when you are doing only IHC, you are leaving out that possibility of functional loss. You don't know whether there is a functional loss or not. Protein is there, but whether that protein is functional or not, we don't know. Because IHC will check whether the P53 protein is there or not. But IHC will not check whether that protein is functional or non-functional.
No doubt, and
Yeah.
suppose you've done TP53 and it is positive.
Yes.
Should be subject their relatives for screening.
TP53 is like generally in endometrial cancers, the most your mutations are sporadic, not germline.
Yeah.
And germline concept is only for endometrial carcinomas for MMR. TP53 genes, they are not germline here in this. Here, if you check the VAF also, in this particular report is 17.43.
So it is MMR which we need.
Yeah,
for
MMR.
screening or
Yeah.
any genetic test.
Yeah. And generally that rule is there that whether it's a percentage of molecular frequency is more than 50%, then we can doubt. But again, we cannot surely say from the somatic sample that it can be germline or not.
Does it mean that if you've done MMR or MSI by or Sanger or PCR,
Yeah.
will that mean they're all Lynch syndrome?
No.
Only a part of them can
Yeah.
be Lynch syndrome.
Yes. Yes.
Any percentages or something about this symptom?
Percent. It's a category. Yeah. It's
Okay.
Lynch syndrome. Deficient.
Endometrial cancers were 3% of them will be.
So we don't know actually to screen if you want to really.
There are ways to guess it, but yeah.
So genetic role of genetic counseling will come into that.
How do we test for Lynch syndrome?
Lynch syndrome is you will test for MMR, and again with MMR you will test for MLH1 promoter hypermethylation. I have a slide, I will show you that.
That is very important.
Yeah, I have a very good presentation on MMR, so I'll show you some slides from there. So that criteria is always there because when your MMR deficiency comes, the genetic counselors, they will ask for the history of the index patient also and the familial history also. And if in the familial history there is a line of this Lynch syndrome related cancers, so then definitely testing will deviate towards that. So that is a normal genetic counselor's rule they apply, how to counsel patients for Lynch syndrome or not. What about? Double classifiers means, well, like where two mutations are positive. Poly mutation. Yeah. So we are reporting, I think from last 1 year, lot of cases are there, but these are very rare where both TP53 and poly are mutated. I have never seen the report. Maybe the incidence will be there, but I personally have never reported both as positive. TP53 also and poly also. So the incidence will be definitely there. But
there are different implications that will be discussed in the next talks. What if they get both that they will not get positive or not? Dr.
Yeah.
Prashant and Dr. Francis will check.
Yeah, but the classification has not included till now double classifiers. Because maybe the incidence is very rare or. So this is the IHC report you will get where you will get the all the 4 genes, you will get the IHC expression, MSH2, MSH6, MLH1 and PMS2. And this is your MSI report, where you will get the final impression is whether it's MSI stable or unstable. I'll show you that slide. This will clear all your doubts for MMR. So we all know there are 4 genes, this MMR related, MLH1, PMS2, MSH2 and MSH6. First of all, what is this? This is mismatch repair protein along with your Pol-E, which is a polymerase enzyme during your replication. So this is again a very important protein which plays a role in your replication process. MMR, mismatch repair protein. This will detect and correct mistakes during replication. So this is a very important protein in each and every cancer, because why these mutations are happening? Because this is the culprit. Because during your replication, there are high chances of getting a wrong nucleotide inserted. But these are the proteins, Poly and your MMR, who will rectify these mistakes. And these are the 4 genes responsible for it: MLH1, PMS2, MSH2 and MSH6. And what is MMRD? MMR is mismatch repair defect, or MMRD tumor is mismatch repair deficient tumor. So absence or loss of function of one of these MMR proteins. So we can detect this simply by looking for absence or presence of these proteins in the cell. So the technology is IHC, immunohistochemistry, where we will check the expression of these 4 genes. So this is your under the microscope, this is the normal expression and this is the loss of expression. And now these 4 major MMR proteins, they always exist in stable pairs. So there are 2 pairs, MLH1 plus PMS2, MSH2 and MSH6. So they will be functional in the pairs. So the rule is, if MLH1 is absent, PMS2 is always absent. So there is a pair of MLH in the previous slide, MLH1 plus PMS2. So if MLH1 is absent, PMS2 is always absent. So same way, if MSH2 is absent, MSH6 is always absent. So initially when the diagnostics IHC started for these MMR endometrial carcinoma, so doctors, they order only for MLH1, PMS2 and MSH6. So if PMS2 is absent, so that means MLH1 is always absent. So if MSH6 is absent, MSH2 is absent. So but nowadays we are checking all the 4 proteins. PMS2 and MSH6 can be absent without affecting the expression of the other protein in the pair. So now this is MLH1 promoter methylation and corresponds to MLH1 loss plus PMS2 loss. Because I told you, when MLH1 is absent, PMS2 is always absent. So you need to just remind this rule. When MLH1 is absent, PMS2 is always absent. So if you are checking only MLH1 promoter and the promoter is hypermethylated, so that means MLH1 is not working. So when your MLH1 is not there, PMS2 will not there. Second is MLH1 gene defect. So if there is a defect in MLH1, MLH1 will not be there, and MLH1 will not be there, PMS2 will definitely not be there. Second is PMS2 gene defect. So only PMS2 loss will be there. We cannot say when PMS2 is not there, your MLH1 is also not there. It's otherwise. Because the pairs are like that, MLH1 plus PMS2, MSH2 plus MH6. So when MLH1 is not there, PMS2 will definitely not be there. When MSH2 is not there, definitely MSH6 will not be there. MSH2 gene defect. So when MSH2 is defective, the gene is defective, MSH2 gene will not be functional, and MSH6 will also not be there. And if only MSH6 gene defect, so isolated MSH6 loss. So that's why, because there is a lot of confusion in the functionality of these pairs. So nowadays, you need to go for complete panel by IHC and by PCR, MMR by IHC, where we will check all 4 proteins. Yeah, all 4 proteins by IHC, MLH1, PMS2, MSH2, MSH6, and MSI by your PCR or Sanger, where you will get that whether the MSI is stable or unstable. So MSI, MMR, IHC, the major problem is always the poor fixation of the tissue. That's why the role of MSI by molecular diagnostic, PCR or Sanger came into picture. Again, if I... So the thumb rule is you have to check all the 4 proteins by IHC and you have to check MSI by PCR or Sanger. Results from sporadic MLH, because when MLH1 is not there, MLH1, PMS2 will also not be there. So all taking into consideration all the confusions and controversies, it's better to go for the complete panel.
I think we can summarize whole thing in just 2 lines again.
Yeah, so take home messages, apart from your FIGO classification, you need to have molecular classification also, or for TP53, for poly and for MMR. TP53 and poly by next generation sequencing, and MMR both by IHC and your molecular either by Sanger or PCR. And then once you have the FIGO histopathological classification and your molecular classification, then classify into the risk subgroups, because this will help not only for your risk stratification, but your therapeutic decisions also. Yeah. Thank you so much.
I know it's a bit confusing about this MMR, and I think it's always no initial hesitancy to understand. And slowly, when it becomes a necessity, we'll automatically understand everything. So once you start doing, we ourselves are sort of, it takes time. So once you start doing things and slowly become, when you will become and you'll start understanding. So
I think it will make more sense probably once you hear the clinical implications. Okay. And even though it's going to cost a little bit more for the patients, it's not available in Jupma. We are also sending outside to the core diagnostics and we're getting the reports. We've already done for some 4 or 5 patients actually, especially the poly, and it really makes a difference in the management. Which is just touched upon in the next 2 talks. Any doubts for Dr. Saditi, I can ask whether she will be giving. Her flight is from Chennai at 9:30, so she'll be leaving. So if anybody has to clarify anything, please you can ask her.
I can share my number also to ordering, like if you have any doubt in the report, interpretation and all.
Sure, we'll do that. Thank you so much.
Thank you. Okay.
So if there are no doubts, a big round of applause for Ms. Aditi. And I would request Shachikala ma'am and Lata ma'am to come and give a token of our appreciation to Ms. Aditi.
So we heard about the molecular profile of endometrial cancer. Now, how will it help us? We are having so much of doubts in our minds. How it will help us? What are the clinical implications of molecular profile? To shed light on this topic, we have with us Dr. Francis V. James, Professor and Head, Department of Radiation Oncology. He will be joining us virtually through Zoom. and he will be speaking on the clinical implications of molecular testing in endometrial cancer.
Good afternoon. Am I audible?
Yes, sir, you're audible.
Hello.
Welcome, sir.
Thank you. Good afternoon.
Are we
Thank you,
audible?
Doctor. Thank you, Dr. Veena and
Are we
Shyama for
audible,
inviting.
sir? Are we audible?
Yes,
Okay.
thank you.
So welcome and please go ahead, sir. A lot of people are waiting to listen to you.
Thank you. Thank you, Veena and Prem, Shyama, Prem, for inviting me to this program. And can you see the slide? Can you see the slide?
No, sir, we are not yet able to see the slide.
Okay, 1 second.
The light off.
Can you see?
Yes, sir, we can see. Only thing is it has to be in slide.
Okay.
Yes, sir. Yes.
Okay. Thank you. In the 1990s and early 2000, we used to treat a lot of patients with intermediate risk with pelvic radiation. And then the first major trial which tested whether we need to give pelvic radiation or vaginal brachytherapy alone is sufficient was tested by Professor Peter Blake from Royal Mass in London. And that was the trial called Aztec. And that showed that only vaginal brachytherapy is required for a lot of patients with intermediate risk. This was the classification used by that team. And low risk involves stage 1A, B, and grade 1 and 2, where there was no adjuvant treatment. Intermediate risk were vaginal vault brachytherapy, then high risk pelvic radiotherapy, advanced stage pelvic radiotherapy plus or minus chemotherapy. So that was a simple classification by British people. There was no high intermediate risk in that. And their Aztec trial proved that vaginal brachytherapy would be sufficient for the intermediate risk group. So a lot of patients who used to get pelvic radiotherapy stopped getting radiotherapy. And that was our practice too from 2008 onward. So the vaginal vault brachytherapy refers to post-operative radiation usually given after 6 weeks of surgery, giving 3 insertions of vault brachytherapy in the vagina. We used to give 7 grade to 0.5 centimeter prescription and given to the upper half of vagina. So basically covers the vault and upper portion of the vagina. When we think about pelvic radiotherapy, we are giving 45 gray in 25 fractions. That's 5 weeks treatment, or 46 gray in 23 fractions. When we give pelvic radiotherapy, we treat the vault plus the lymph nodes. So that's the 2 types of adjuvant radiation treatment being delivered to these patients. In our hospital, after this policy was introduced, from 2009 to 2013, we looked at 686 patients, and the 3-year disease-free survival was 80.6%. And these patients are treated based on the Aztec criteria, which is if 1 risk factor is there, vaginal brachytherapy, if 2 risk factors there, pelvic radiotherapy. From stage 3, along with pelvic RT, add chemotherapy. Stage 4, as you know, is mostly chemotherapy plus or minus local treatment. And we have published those materials. And the 3-year disease-free survival was 80.6%. And then came the major change by SJO risk grouping in 2016. As the risk grouping was combined with SJO, ESMO, ESTRO group, and they classified into low, intermediate, high, and advanced metastatic. So low was the patients with very favorable group who didn't require any treatment. Intermediate was patients with more than 50% myometrial invasion and who were LVSI negative. High intermediate were grade 3 with less than 50% myometrial invasion. Then patients with LVSI positive. And then coming to high grade, high grouping, risk grouping, there are stage 2, stage 1 deep muscle invasion and myometrial lymphovascular invasion, and stage 3, all those fell into high risk group. Those are patients who are basically considered for pelvic radiotherapy and chemotherapy. Then comes the advanced stage after. So at that point of time, people are following that risk categorization for adjuvant treatment recommendation. And then 2021, the same group came with a modified classification, which is based on both clinical and molecular classification combined. So if you have the information of molecular classification available, then you go to the right-hand side. If you don't have the molecular classification status, then you go to the left-hand side. Both are basically classifying patients into the risk groups mentioned earlier: low, intermediate, high, and advanced. So in our patient groups, we wanted to see how these risk groups change between 16 and 21. In 16, we find that a lot of patients fall into risk group 4 with 254 patients. And there's a good number of patients in risk group 1 also, 216. But in the 2021 group, we find that patient groups are fairly well distributed between 1, 2, 3, 4, so which appear to be a better grouping. So when we looked at the disease-free survival of 2016 and 2021, we find that the crowding at the top in the 2016 has gone. So there is better differentiation between this risk grouping. So 2021 risk grouping is considerably better based on the wider grouping of these risk groups. So that certainly is a better one. Coming to this is about the historical evolution of this practice of adjuvant treatment. Coming to the summary of these 3 major trials, which made the changes in radiotherapy or chemotherapy of endometrial cancer: POTEC 2, Aztec, POTEC 3, they made huge differences. POTEC 2 and Aztec trials did the same thing. They compared pelvic radiotherapy with brachytherapy. It is done in patients with intermediate risk or high intermediate risk. So the inference of both trials was that if the patient has intermediate or high intermediate risk, if you give brachytherapy, it is sufficient to bring down the recurrence of vaginal vault to the same level. So you can avoid pelvic radiotherapy, which is lengthening and treating more area of pelvis. While brachytherapy is more convenient, patients come to the OPD hospital only 3 times, simpler treatment, less toxicity. So everyone changed to vaginal brachytherapy for high intermediate and intermediate risk patients. Regarding POTEC 3, it was asking another question for patients with higher risk. The pelvic radiotherapy was the practice, and then adding chemotherapy improved their survival. And these results showed that if you add chemotherapy to this pelvic radiotherapy for stage 3 patients, the survival is improved by 10%, which is a good improvement with chemotherapy. Having said that, none of these studies were using molecular testing. But one of the attractions of these POTEC studies was that this was done in Europe, where they have kept all these paraffin block of these patients participating in the trial. So they collected the paraffin block and tested. Molecular testing was done later. So the POTEC 2 trial reported 5-year survival and all those data. And afterwards, they pulled out the paraffin block, did the molecular testing. And just to remind you about who are in the POTEC 2 trial, they are patients with high intermediate risk, which included patients with more than 50% myometrial invasion with age more than 60 years, patients with age more than 60 and had grade 3 disease, patients with the stage 2A disease, which is the olden stage 2A, that is endocervical glandular involvement. So these were the group of patients studied in PORTEC 2 trial. So when they went back and analyzed the data at 10 years, they find there is a very significant difference between the 4 different molecular groups. You find that the polymute ultramuted group, the survival is almost 100%. They do extremely well. So the next is no specific group, which also did very well. And come next is MSI high, then that's an intermediate group. And then the worst group was TP53 mutated group. So you find that 40% of them died of endometrial cancer death. So that's very bad. So the patient numbers, although was low, it was quite evident. The number of patients in that group was only 25. And the most of the patients were no specific group, that was 199. So this study confirmed that the molecular testing is a very valid thing for the survival of the patients undergoing adjuvant treatment under PORTEC 2 study. And they looked at other factors which are not a standard classifier, which is L1CAM mutation, LVSI, all those things were looked at. So they wanted to see what was predicting vault recurrence and pelvic recurrence. So they found that if you give if none of these factors, risk factors other than this was present, if you give pelvic radiotherapy or brachytherapy, most of the vaginal and recurrences are prevented. The vault recurrence is very low. But in patients with L1CAM, which is a cell addition molecule, L1CAM, if it is more than 10%, if there is abnormal P53 or substantial LVSI, then the chance of pelvic recurrence is high, as well as distant relapse. So in those set of patients, you have to give pelvic radiation. Just giving brachytherapy is not sufficient for that set of patients. So that is the finding of analysis, result of the analysis done 10 years down the line. So this is a very useful information. Coming to PORTEC 3, again the PORTEC 3 trial was done not with molecular testing, but they did that testing pulling out paraffin blocks later. As you know, the PORTEC 3 trial showed that patients with stage 3 and serous carcinoma really get benefit out of 4 cycles of chemotherapy after pelvic radiation. So when they pulled out the data and classified based on the molecular analysis, the P53 abnormal group, they did considerably worse. So you can see that the relapse-free survival and overall survival was poor. Only half of them live 5 years when there had been P53 abnormalities. And patients with polymutation did very well, almost 100%. And the MMR deficient and NSMB did intermediate. So this is again showed very clearly that in PORTEC 2 and PORTEC 3, this molecular classification is very predictive of what will happen to their life. So this is very useful thing. So previously, Dr. Aditi spoke about all the molecular stuff. Now you have the clinical evidence clearly showing that this makes a huge difference in their survival. So this led to further studies. Can you de-escalate treatment? And the PORTEC 4A trial is happening. The result is not yet available. So they classified patients into possibly favorable, intermediate, and unfavorable group. The unfavorable means this is about patients with stage 1 and 2 only, not for stage 3 and 4. So early stage 1 patients, high intermediate risk, they look at substantial LVSI, P53 mutation, or more than 10% L1CAM expression, they call it unfavorable. If the patient has fold mutation, they call it favorable. If the patient has MMR deficiency, then they call it intermediate. So these patients are modified into a treatment program where they get, in the control arm gets only vaginal brachytherapy. In the experimental arm, they are observed. Vaginal brachytherapy is given. Pelvic radiotherapy is given because based on favorable, intermediate, and unfavorable group. So the result data is not available because we have to wait for the result to come through. This will be one of the good tests of the principal molecular based trial. So we'll have to wait for the result. Coming to the rainbow trial, which have been mentioned again, this data is also not available. This trial is undergoing evaluation, and I'll just mention about rainbow blue, which is testing if the patient has stage 1 to 3 and POL mutation is there, then they are testing whether no adjuvant treatment is a good offer to this set of patients. And currently they'll be treated based on standard treatments. So that will prove whether we can avoid any treatment for this patient group with POL mutation. And the others are testing different questions in P53 abnormality, adding olaparib, which is a PARP inhibitor, and in MMR deficient patients, adding an immunotherapy, whether it will improve survival, and in NSMB, whether adding hormonal therapy will improve their survival. So these answers will be available only few years down the line. I'll just mention about GOG trials. One, not to say anything about American trials. Second, for completion's sake. So they GOG 249 tested in stage 1 and 2. They compared 3 cycles of chemotherapy with vaginal brachytherapy versus pelvic radiotherapy. The survival were similar. So the standard arm was pelvic radiotherapy, so that remained like that. And in 258, the patient group was stage 3 and 4. They tested 6 cycles of chemotherapy versus pelvic radiation and 4 cycles of chemotherapy. The survival was similar. So the Vortex 3 experimental arm, which is pelvic radiotherapy plus 4 cycles of chemotherapy, was similar to 6 cycles of chemotherapy. So if you want to avoid pelvic radiotherapy for some patient, it may be possible with 6 cycles of chemotherapy with some increased risk of vault and pelvic recurrence. And so coming to the final recommendation based on this molecular classification, as I mentioned earlier, the STO classification says low risk for this set of patients. Stage 1 and 2 with POL ultramutated, and stage 1A MMR deficient or no specific molecular pattern. Then we call it a low risk group, and they are observed. We don't offer any adjuvant treatment for this sort of patients because they do very well. These patients in the non-specific molecular marker group, it has to be low grade and LVSI negative. The intermediate risk are patients with stage 1B, that is more than 50% myometrial infiltration with no LVSI. Then stage 1A with high grade, no LVSI. Then stage 1A, that's less than 50% myometrial infiltration with P53 abnormal, but there should be no muscle invasion. The standard treatment now will be vaginal brachytherapy, 3 sittings of vaginal brachytherapy, giving 7 grade times 3, and that's the common treatment. And the patients below 60 years, maybe they do even better. Maybe we can avoid any treatment. Again, stage 1A, P53 abnormal limited to the polyp, maybe no treatment is required. Coming to high intermediate, that's stage 1 patients with MMR deficient or no specific markers. When there is substantial LVSI, or stage 1B patients who are high grade, or if the patient has stage 2, then they come into the high intermediate risk group. And then the common treatment will be external pelvic radiation, treating both vault and pelvic lymph nodes. And coming to certain situations, like if they are POL mutated, no adjuvant treatment may be an option. That will be a standard option now for stage 1 and 2. If they are P53 mutated, chemotherapy will be considered. Coming to high risk, group, that's stage 3 and 4A. If they are MMR deficient and no specific markers are available, postoperatively they receive pelvic radiation and 4 cycles of chemotherapy as in PORTEC 3 trial, or some patients receive chemotherapy alone. Again, if they have P53 mutation, data is available. It won't make any difference because by stage 3 they will receive chemotherapy. When there is POL mutation, we are not sure whether it can be spared of treatment in stage 3. So we'll have to wait for some time to avoid chemotherapy in this set of patients. Then we come to the final advanced stage patients who have stage 3 or 4 who have residual disease after surgery, or patients who have stage 4B. Here, molecular typing doesn't make huge difference. You'll have to treat the patients with systemic treatment, which is chemotherapy or immunotherapy or which all things. And local treatment is surgery or radiotherapy. And the steps of molecular classification have already been alluded to by Dr. Aditi. So we'll check whether they are MMR deficient or POL mutated. And if those tests are done, if they are MMR is intact and POL is wild type, they go and do P53 testing. But if you have short of money, the British Association of Gynecologic Pathologists have recommended this pathway where we can limit the testing of poly. So if you are depending on IHC for testing other things like MMR, P53 and all, then you can select which all patients to undergo poly testing by NGS testing. So patients with stage 3 and 4, they would anyway need systemic treatment. Much alteration in treatment is not usually going to happen. So they may not need poly testing. So you can save money there. And the other set of patients with a very low grade ER/PR positive, low grade endometrioid, they may also need not undergo poly testing because they are observed, they are not being offered any treatment. So that's one way of saving some money. So in summary, we are moving from the old histopathology method to a molecular-based decision-making to recommend treatment now. This molecular classification helps to find out prognosis and tailor treatment. However, we are still keeping higher stage, positive LVSI, non-endometrioid histology, which are all well-known poor prognostic factors. Until prospective randomized molecular-based clinical trial data is available, we are cautiously treating patients based on a mixture of morphological and molecular studies. Thank you.
Thank you, sir.
Thank you.
So there are some questions over here in the chat box. I'll just.
Sure. Okay. Well, shall we do it afterwards or all together or just few?
So will you stay till the end, sir? Then we can have the questions together at the end of the session. One more talk is there by medical oncologist. So we thought we will have it after that. Will you please stay back till that time, sir?
Yes, fine. Thank you.
Thank you so much, sir. Thank you so much. We'll take the questions later.
Our next talk is on therapeutic implications of molecular testing. And to give this talk, I'd like to invite on stage Dr. Prashant Ganeshan. He is the professor, Department of Medical Oncology, Gynecology. Over to you, sir. He's an integral part of our tumor board in Gynecology.
Thank you. Good afternoon. These are very tough topics actually, because this molecular classification is always very confusing and all cancers are going this way. So unfortunately, it's something which we cannot escape as we go along, because this is the present and definitely the future of treatment of most cancers. So whether we like it or not, we have to get on with it. So this is an attempt to help us understand things as they stand today. One thing before I start, one disclosure and one important thing which everybody has to understand is that these things will keep changing. So what you learn today may not be the same implications 6 months down the line or 1 year down the line. Things will definitely keep changing. So this is as we understand the evidence and the literature as of today. This is a very rapidly changing field, so we have to take it in that context. But I think it's very important from all perspectives. Gynecological cancers, especially endometrial cancers, in which multiple departments are involved. And this is one cancer where the molecular implications start from stage 1 up to stage 4. In many cancers like lung cancer and all, mostly the molecular implications are only in stage 4 disease. Now maybe a little bit in the earlier stage, but this is something which everything is impacted by the biology or the molecular biology of the disease, not by the external manifestations as we used to know it before. So that's the idea of this. So endometrial cancer, my primary idea today is to talk about the systemic therapy part. But I would like to try to give an overview of the whole thing, just to put things into perspective, because I think a lot of residents here. So I'll try to simplify as much as possible. But again, my apologies, because it's not really a simple area of yeah, I know. Yeah. So endometrial cancer, most of you are well aware. Most of them fortunately present in early stage disease, and they have excellent outcomes in stage 1 and stage 2. And if they do present in more advanced stages, the outcomes are quite bad. So this is in a nutshell what we have discussed and we are going to discuss today. I've tried to put everything into one slide, okay, just so that you get an overall picture, okay. This is not perfect. There may be some things which are missing here. I'm not trying to understand the current staging system, because I find the staging systems always very challenging. And again, that also keeps changing once in 2 years. I don't try to remember staging of any cancer anymore. So, this is to understand from a treatment perspective, okay? So when we talk about low risk disease, primarily these are endometrial cancers where we do surgery and after that we don't want to do anything else. We don't want to give radiation. We don't want to give chemotherapy. So we want to identify that group of endometrial cancers where we can just do surgery and leave them alone. So which is this group, okay? Traditionally, we know that these are stage 1A, grade 1, 2. This was traditionally what we knew. What is the new thing here? Polymutation, okay? That much you have to remember, okay? Once they are polymutated, it doesn't matter whether they are stage 1, 2, what are the other features. The moment you find polymutation, they are going to do extremely well and you don't have to give any adjuvant therapy. Now, the only controversy here is if it is stage 3 and polymutated, whether in that situation, whether you should give adjuvant therapy or not, okay? This is really not answered well at this point of time, okay? Because the data which is coming from the so-called clinical trials is very minimal. The subset which you get of stage 3 polymutated is such a small subset. So this question is not well answered, okay? That is why you have these trials like Rainbow, etc., which is coming up, which are going to try and answer these questions as we go ahead. So the information will be available. At this point of time, if you have a stage 3 patient with polymutation, should we give radiation? Should we give chemotherapy? Is not clear, okay? Some guidelines say that, yes, you can observe these patients. They seem to do well. Some say that, no, at this point of time, there is not enough data. You treat it like any other stage 3 patient. So this is where we stand. Now, if you have intermediate disease, that is any of those bad boy things which our Dr. Indranil so nicely put it together. So they are bad boys, but they are stage 1, okay? Now, you generally give vaginal brachytherapy. You don't really do chemotherapy in these stages. The data comes from the PORTEC-3. If you are high intermediate disease, you generally get into EBRT. And here, some of them may require chemotherapy plus minus, especially if they are stage 3, grade 3, or most of them say substantial LVSI. Okay, so this is the term which is mostly used in the recommendations. If they have substantial LVSI, stage 2, grade 3, you want to consider chemotherapy. This data again is coming from some subgroup data from the PORTEC-3 trial. most of the chemotherapy recommendations are coming from the PORTEC 3 trial. So this is the summary for the high intermediate. High risk is relatively easier. This is all your stage 2, grade 3s, all stage 3 diseases. All non-endometrioid histologies are generally considered as high-risk disease for endometrial cancer. And the new thing here is the P53 mutation. Okay. So practically you have to remember only poly mutation is good risk, P53 mutation is high risk. So, okay, this is the primary molecular implications as far as the early stage endometrial cancer is concerned. For advanced stages, there are more implications that we will talk about. So in high-risk disease, currently based on the PORTEC 3 data, we generally give both EBRT as well as chemotherapy. So that is the data. Now, advanced stage disease is anything else. That is stage 3, a lot of residue is there, stage 4A, 4B, all of them. There is a role for surgery. Of course, we all know that even in stage 4 disease, there is a role for surgery in endometrial cancer. And there is a definite role for chemotherapy, and there can be a role for radiation depending on the circumstance. This is in a nutshell what we currently do and where the molecular testing fits in. Now I'm going to go into the detail. Please again remember that this entire thing until the high risk, whatever I talk about, primarily talks is for the endometrioid histology. The moment you have serous, clear cell or any of the high risk histologies, it goes here. Okay. So we're going to talk about the molecular implications of systemic therapy in adjuvant setting as well as in the advanced setting. So quickly, this has been covered before. Again, just to summarize again, so that because there are a lot of postgraduates here, these 3 trials, you remember at least what they are, because that keep coming in endometrial cancer. There are a lot of other trials because these are the ones which have made a lot of impact. PORTEC 1, if compared stage 1 disease, you have done surgery, whether you should give radiation or not. That was the question which was asked in the PORTEC 1 trial, which clearly showed that when you use radiation, you reduce the loco-regional relapse significantly, especially when there are some high-risk features. So all that data which we talk about, where in low-risk disease, you don't have to give radiation. If these high-risk features are that you give radiation, that data comes from the PORTEC 1 trial. Once they knew that, then they did the PORTEC 2, where there is a slightly stage 1 higher risk disease, where they compared EBRT versus vaginal brachytherapy. And then once they had that information, then you have the PORTEC 3 trial, which predominantly concentrated on the high risk disease, where the question of addition of chemotherapy was asked. And here again, if you look at the primary data of the PORTEC 3 trial, it does not clearly say that chemotherapy plus radiation is beneficial as a whole in endometrial cancer. But definitely you could tease out a lot of subgroups where the benefit seems to emerge. So again, it's important because a lot of systemic therapy recommendations comes from the PORTEC 3 trial. It's important to know what went into the PORTEC 3 trial, who went into the PORTEC 3 trial. So PORTEC 3 trial is high-risk disease, and this is how they define the high-risk disease. That is stage 1A endometrial cancer, grade 3 with LVSI. Stage 1B endometrioid cancer, which is grade 3. Stage 2, 3, 3A, 3B, 3C, and any serous or clear cell histology with stage 1A, 1, 2, or 3. Okay. So this is the inclusion of the PORTEC 3. And before I show how the molecular implication of the PORTEC 3 comes, again, I just want to, for the sake of, again, this is all for the postgraduates who may not know this. We keep talking about this TCGA, PORTEC data, everything. I just want to make you understand this. TCGA is a consortium. Okay. This is Genome Atlas Consortium. This is an international consortium which is funded by some philanthropy. Okay. It's not belonging to any government or any single person. So they collected tumor data from across the world. So basically tumor tissue was contributed from India, from US, from Europe, across the world, from everywhere they got 10, 20 tumor tissues of each types of cancer, including the clinical data pertaining to that. And with this tumor tissue, they did genomic analysis of the tumor tissue in great detail. There was like complete sequencing of the entire genome to understand what was different in the tumor as compared to a normal genome. Okay. This was the first understanding of the entire genome and its complexity for each specific cancer. And from the analysis of this data, they could understand that genomically, there are 4 types of endometrial cancer. Okay. And this is how the initial classification came. So out of 100 patients, 5% were polymutated, and the remaining so many were having this MSI, that is MSI status. And then out of the remaining, some of them were copy number low, some of them were copy number high. Okay. Again, why these terminologies are different is because these original terminologies are terminologies as used by the TCGA. So TCGA used these terminologies as polymutation, MSI, and copy number. Again, this MSI and MMR, let me again explain it to you. When you are testing for the protein expression in the tissue, okay, of these MMR genes, the previous speaker already explained that the MMR genes are like protectors, no? They prevent DNA damage, okay? When any of them are not there, there is a lot of DNA damage. And these proteins are coming from the genes. If the gene is mutated, you don't get the protein. So this is what we are testing for. So you can test for the protein. If the protein is absent, you assume that the gene is not working. Okay, so this is the assumption. So one way is to test for the protein. Okay, another way is to test for what happens to the genome when the gene is not working. So when the gene is not working properly, the genome accumulates a lot of mutation, because this is what the gene is supposed to do. The protein which comes out from the gene is supposed to protect the genome from multiple mutations. So when the gene is not working, the protein is not there, then the genome accumulates a lot of mutations, and these mutations are manifested as microsatellite instability. Okay, that is the manifestation of MMR gene defect. Okay, so to identify the MMR gene defect, you can do actually three things. One, you look for IHC for the protein. You can look for the MSI in the genome. You can look for microsatellite instability in the genome, or you can do direct testing of the MMR genes itself for mutations. There are three ways in which you can identify these things. Okay. Now, what we find is the easiest thing is to do the IHC, because that is simple and that is easily available in most centers. And surprisingly, we have found that the IHC is good enough. 90% of the time, if you do MMR testing by IHC, that is enough for us to understand that there is a genetic defect. Okay, so that is what is currently recommended across the board. It's not necessary that we should do genomic testing or we should do MSI testing in all cases of where we are testing for MMR deficiency. So for your understanding, MMR genes are there, 4 genes. From that, you are getting the MMR proteins. That's why you are checking by IHC. When the proteins, any of them are not there, the genome is faulty and you get MSI, unstable status. Okay. Now, again, the other thing which comes up is when you should do testing for Lynch syndrome. Okay. Lynch syndrome is a genetic disease where there is genetically in the genome, in the germline, there is defect in any of these 4 genes. Okay. A defect in a cancer can happen only in the cancer itself. That is called a somatic mutation. In the cancer cell only it has happened, or in the entire body, all the cells are having that gene defect. That is a germline defect. Okay, in a Lynch syndrome patient, the entire body, all the cells are having some defect in the one of the MMR genes. So that person is a Lynch syndrome susceptible patient. That person is susceptible to get endometrial cancer. Okay. But if you take 100 endometrial cancers, only a proportion of them are having Lynch syndrome, but many of them will have defect of the MMR deficiency, MMR genes, which is happening only in that particular cancer. So this is the difference. Okay. So in terms of percentage, if you take 100 endometrial cancer samples, 30 of them will have MMR deficiency. So there is a problem there. Among them, only 3% of them will be Lynch syndrome. Okay, so if you find MMR deficiency and if you want to test for Lynch syndrome in that particular patient, you have to test it on the germline. That means you take a sample either from the buccal mucosa or from the blood and you test it. And if those cells are having that, then you label that this is a germline problem. Otherwise, the problem is only in the somatic tissue. Okay, so this is for your understanding. That's why I went into the details. Now, this data comes from the TCGA, this classification. Now, this information we have to apply in the clinic. So what they did was, this data was available from the PORTEC 3 trial patients. Already they have been treated. All the samples were there. They took these samples and then they tested for these 4 genes in those samples. And they found that 12% were polymutated. Please remember here they saw 5%, here it's 12%. Because here you're testing on all the cases. Here you're testing only on high-risk patients. So this is the difference why it comes like that. And you have 33% deficient MMR, 32% which cannot be classified, and 23% were P53 abnormality. This is how the clinical implications are understood. And when they looked at the data, they found that yes, who are pole mutated are doing extremely well. Even though they are high risk, you can see there's hardly any relapse, 100% survival almost. And these two are somewhere in between, and the P53 is doing bad. Now, which treatment helps in these kind of situations? So this is the next thing that you want to see. So when I coming to my part of the talk, where chemotherapy matters in an curatively treated endometrial cancer. So first thing, you look at the P53 abnormal endometrial cancers. So if you see these curves here, the maroon one is those who are treated with chemotherapy and radiation. And the blue ones are the ones treated only with radiation, because that is the two arms in the trial. If you took the patients who had P53 mutation, you can clearly see that the benefit of chemotherapy is maximum here. Prognostically, this is the group with the worst prognosis. P53 mutated is the group with the worst prognosis. You can see in the previous thing. But the benefit of chemotherapy is maximum within that group. Okay, so that's why we keep using the terms, what is prognostic, what is predictive. So P53 is prognostic as a whole, but it is also predictive for response to chemotherapy when you are treating endometrial cancer. Okay, so if you have P53 mutation, we say definitely you should give chemotherapy, because you can see this margin is huge. The benefit margin is huge. Whereas if you have P53, okay, this is the overall survival curve of the same thing. Yeah. Okay. Now let us look at the poly mutation. The poly mutation is already doing well, irrespective of whether you give chemotherapy or if you look at the PORTEC-2 data, whether you give radiation. The poly mutated patients are doing extremely well. You cannot do better than this. So there is no need to give chemotherapy in these patients. So that is the implication of the poly. Whatever you do, they are going to do well. So you don't do anything. Now come to the other two groups. This is not a small group. That is again almost 50 to 60% of your endometrial cancer is going to be in these two groups. So 30% are MMR deficient. Here again, there is hardly any benefit of chemotherapy. Chemoradiation and radiation are almost on top of each other. So here, there may not be any benefit of adding chemotherapy in MMR deficient. That is also well known actually. If you see, there is similar data from colon cancer that in MMR deficient colon cancer, you don't get benefit from chemotherapy. So this is the same thing that is replicated here. And if you look at the NSMP, here, if you look at the relapse-free survival curve, there is some benefit. Okay, even though the p-value is not significant, the overall survival curve, there is no benefit actually. So here it is still not well defined, because this much patients only were. Remember, this is all subgroup analysis of a clinical trial. Subgroup analysis should always be taken with a lot of caveats. So this is not the primary endpoint of this trial. These are all secondary analysis which is done later. So, but this is important implication because it's a fairly large, well-conducted trial. So to summarize, P53 mutated, definitely give chemotherapy. Poly mutated, don't give chemotherapy. But stage 3 poly mutated are not well represented in this group, so we do not know. MMR deficient and NSMP, again, the RT alone and chemo RT, no difference in survival. You may omit chemotherapy, but currently it is not very clearly defined. Okay. Now going to systemic therapy in advanced endometrial cancer. Before I go into the molecular implications, I just want to summarize where we stand with respect to systemic therapy in advanced endometrial cancer. So basically, you look at MMR proficient. The current standard of care in advanced endometrial cancer is only chemotherapy. The standard chemotherapy which we use most of the time is a combination of paclitaxel and carboplatin. Whether you can use checkpoint inhibitors here is not clear. There are a couple of trials which seem to suggest that you can use it, but I'll come to that. There is a subgroup of endometrial cancers which express HER2 overexpression or amplification, just like breast cancers which are HER2 amplified. This is about 10% of endometrial cancers. In that, there is a benefit of adding anti-HER2 agent. The standard anti-HER2 agent is trastuzumab. If you have an MMR deficient tumor, this is a new thing which has come in the last year or so. If you have an MMR deficient tumor, the standard of care is not chemotherapy anymore. I'll show you that. The standard of care is chemotherapy with checkpoint inhibitor. In a very rare subgroup of advanced endometrial cancer patient, maybe who is somebody who is old, who has minimal symptoms, who has grade 1 tumor, who is ER/PR positive, there may be a possibility of not using chemotherapy, use only endocrine therapy. This is the current summary of the first line therapy. What is the new thing here? This is the new data which has come out in the last 1 year or so. This is the frontline trial comparing carboplatin paclitaxel with or without pembrolizumab, which is an immune checkpoint inhibitor, as first-line treatment for patients with advanced endometrial cancer. And this is why the standard of care changed. As you can see, this hazard ratio is 0.3. This is huge difference actually. This kind of difference normally you don't see in cancers with systemic therapy. This is massive difference. So that is why now the recommendation is use pembrolizumab in first-line therapy in endometrial cancer. This is similar data with a drug called dostarlimab, which is currently not available in India, but it is also a checkpoint inhibitor. You can see the hazard ratio is very similar, 0.3 here. And this is for the overall survival also. There's one more trial, I'm just showing that for subgroup purposes. This is using atezolizumab, which is also a checkpoint inhibitor. Again, you can see similar kind of hazard ratios and similar kind of benefit. Now, here again, one thing which I wanted to show was this picture on the left-hand side. When this trial was done, they did not differentiate between deficient MMR and proficient MMR. They included all patients with endometrial cancer. But when they did the subgroup analysis, you can see this is the deficient MMR cohort and this is the proficient MMR cohort. As you can see, the maximum benefit is in the deficient MMR cohort. In the proficient MMR cohort, it is still there, but it is much lesser. The same thing repeated with the dostarlimab trial and a similar thing in the atezolizumab trial. So that is why the current recommendations say in deficient MMR, you go for immune checkpoint inhibitor with chemotherapy. In the proficient MMR, the recommendation is still not come. Some of the guidelines say that you may consider whether you should test. So again, because in the context of molecular testing and things like that, whether you should test for PD-L1 because that's an important marker for immune checkpoint inhibitor therapy. So if you are deficient MMR, the PD-L1 testing does not matter. If you are proficient MMR, probably it does. The PD-L1 seems to have a more benefit, but again, this is again subgroup analysis from this trial. So again, I won't go into the details. So this is the current first-line therapy for endometrial cancer, and the molecular implication is that you must check for MMR deficiency. If they are MMR deficient, we should definitely use immune checkpoint inhibitor in the front line. What about second-line therapy? Here, there is more options of targeted treatments. Again, in the second-line therapy, again, if you have an MMR deficient tumor, the recommendation is use checkpoint inhibitor, especially if they have not been exposed in the first line. If you used only chemotherapy in the first line, you can use checkpoint inhibitor in the second line. Please remember, an MMR deficient endometrial cancer in the second line, you don't have to use chemotherapy. You can use only pembrolizumab. So that is also an option here. Similar to first line, you can consider endocrine therapy in a very selected group of endometrial cancer patients. In addition, we all know there is something called a high tumor mutational burden, which can be checked using next generation sequencing. If there is high tumor mutational burden, these patients respond to immune checkpoint inhibitor therapy, irrespective of what cancer it is. These are called tumor agnostic indications. So if you have a high tumor burden, you can use checkpoint inhibitor therapy in these patients also. But to test for TMB, you need a very good NGS testing, which is currently actually not available in India. If you are an MMR proficient tumor in the second line, the current standard of care is pembrolizumab plus lenvatinib. The other things which you can test for are NTRK mutations, again tested through NGS, and you have specific therapies for this like larotrectinib, entrectinib. Why I am telling that is, when these patients are identified, they do extremely well on these therapies. However, they are only 1% of endometrial cancers. And if you have P53 wild type tumor, they benefit from a drug called selinexor. So these are the molecular testing implications in endometrial cancer in a more advanced cancer setting. So, so this is HER2 testing. I already talked about it. Paclitaxel, carboplatin plus trastuzumab can be used as frontline if there is HER2 testing. ERPR testing, similar to breast cancer, there's no separate guideline for interpretation of ERPR in endometrial cancer. It is similar to breast cancer at this point of time. And this is NTRK testing, and it has to be done by NGS ideally. This is what I mentioned about selinexor, which is a new drug which is currently used in actually multiple myeloma. But it has benefit only in P53 wild type, does not work in P53 mutated. So if you have that kind of circumstance, you can use this drug also. The drug is actually available in India. So just to summarize the molecular testing implications in endometrial cancer, with respect to radiation. So this data is coming from the molecular analysis of samples which are available from the PORTEC 2 and PORTEC 3 trials. And remember here, majority of them are stage 1 tumors. If you have polymutated, omitting radiation is safe. If you have MMR deficient endometrial cancer, the implication which seems to come is that RT may have a limited role, but this is a bit unclear. If you have P53 mutated, definitely consider EBRT, not just vaginal brachytherapy. If you have no specific molecular profile, VBT may be preferred and it may be better than no RT. So this is the implication for radiation. Implication for targeted therapy is that this is actually from the current NCCN guidelines. They recommend that all patients of endometrial cancer should be tested for MMR proteins. I already showed you why. There's implications both in the early stage as well as in the advanced stage. And there are trials which are going on using immune checkpoint inhibitors in the adjuvant therapy setting also. So we saw the rainbow trial and all those things. So that those implications will also come in future. And definitely P53 should be tested and HER2 should be tested because these are fairly easy tests to do. And ERPR testing may be considered, especially with the recurrent disease, advanced disease, because it definitely predicts response to hormone therapy. This is the current NCCN guideline that a comprehensive molecular profiling or NGS should be done, because then you can identify things like NTRK mutation, high tumor mutational burden, things and all. But again, this is not feasible to do for patients in our country. A comprehensive NGS profile with a good standard lab like Foundation Medicine or something like that costs upward of 2 to 2.5 lakhs just for the test. So this is not something which is practical in countries like United States. It's currently getting reimbursed through their insurance. They've got it approved. So that's why they are able to do that for all patients as part of routine care. So again, this slide again, this is what I initially talked about. We can always come back to this for any discussion purposes. So I will stop here, and you want to do this? Okay. So this is just one simple thing, whether we should really get into this or not. So this is really a back of envelope kind of calculation. So if you do poly testing 10,000, so 10,000 is for targeted poly testing. I'm not talking about NGS. So if you do targeted in poly testing, that will identify 90% of the relevant mutations of poly testing, and the PCR based testing will not cost more than 10,000 rupees, especially if you are doing it regularly. So if you see in a center 50 high-risk patients in a year, you need about 5 lakhs for a testing, because it's 10,000 into 50. And out of these 50 patients, assuming 10% will be poly positive, looking at the PORTEC 3 data, there are 5 patients in which we omit radiation and chemotherapy. Okay. The cost of radiation and chemotherapy for 5 patients, and this costing will be differing from different centers. I have taken the costing from the PMJAY rates. Based on that, you can estimate that the cost of chemotherapy will be 3.7 lakhs and cost of radiation will be about 2 lakhs. So for a center, I'm talking from the center perspective, the cost will be well balanced. You will save about 5.5 lakhs not treating these patients with chemotherapy and radiation, which will be the cost for testing 50 patients for poly. So this is one way to justify that we can go for poly testing across the board for high-risk patients. And of course, there are other ways of cost-effective testing, like you test only 2 IHCs at a time. You don't test everything. You do only MSH2, MSS6, and PMS2, because they are all co-linked. I think the previous speaker alluded to that. So you can just test this and come to some kind of a conclusion. So I'll stop here. I'd be happy to take questions. And I think after this, we are also having some panel discussion questions.
Thank you, Krishna. Thank you so much for this. Trying to simplify something which is not at all simple. It's as simple as that, right? So I think we have some questions which have been raised by different people. They sent it to us on WhatsApp. They put it on the slide here. Francis, sir? So you're available, sir? We'll start the discussion now.
Yes.
Okay.
So the first question is, if P53 is mutated, will it affect the treatment decision? I think. Okay, sir. Please.
Which stage of patient? Histological stage.
This is what the audience have asked, sir. I think we'll have to tell them whether it is early stage or.
So, if it is stage 1 and 2, that information says that the patient is at a higher risk of recurrence. So the patient should get pelvic radiation. But if the patient has stage 3 or 4, automatically because of higher stage, patient goes to have a more aggressive treatment.
Okay, sir. What is the relevance of molecular markers in serous carcinoma of the endometrium? Should we be checking for the molecular markers if the histopathology in the endometrial biopsy comes as serous carcinoma, so uterine papillary serous carcinoma?
That's a good question because it's a conflict of morphology and molecular marker.
Exactly.
Based on the histopathological information available now, they do poorly. So we have to treat them aggressively with chemotherapy and radiation. That's what we commonly do. And if you do molecular testing and if they are found to have, say, polymutated, they are likely to do better.
Okay.
But that information at the moment, I don't think we can recommend clinically because that data is not available. Treating in that pathway. Can you follow me?
I think we should also tell the audience when should we not test for molecular markers. Obviously, there is some cost involved in this. So in which stage we won't test for molecular markers?
If the patient has a stage 3 disease, that is pelvic lymph node or para-aortic lymph node, then anyway you have decided to give chemotherapy and radiation treatment.
Yes,
and doing this test are unlikely to be beneficial to that patient. No confusion.
Okay.
And if the patient has a early stage disease, ER/PR positive, everything favorable, you want to observe the patient. And if you decide to observe the patient doing polymutation doesn't help the patient.
Yes, sir.
So,
okay, sir.
But ISCs are quite cheap, so that is useful.
Yes, sir. So basically, if the patient is apparently low risk, that means stage 1 low grade and stage 1 kind of patients, we do not need to well differentiated tumors, endometrioid, and we need not test for molecular markers. And in apparent high stage disease like stage 3 with pelvic and para-aortic lymph nodes are advanced, again, there is no point of testing for molecular markers. Immunohistochemistry for MMR genes, like, that will be very useful over there also because we can decide about the adjuvant therapy, the use of immune checkpoint inhibitors and all. So the next question is, in stage 3, if pole is mutated, will it affect the treatment decision? I just added stage 3 because obviously the audience already knows, I think. In stage 3, for example, there is parametrial involvement, cervical involvement and parametrial involvement, and the pole testing is positive, ultra mutated. Will it affect the treatment decision?
That's a very good question, which I cannot answer now because because there is no clinical data available for that solution.
Okay,
and as you have seen in the rainbow trial, that's the last bit.
Probably,
the trial is examining whether you can avoid any treatment for
polymutation. I think rainbow trial only they have put as stage 1 to 3. I think if pole mutated, either de-escalate the treatment or skip the treatment altogether. Okay, fine, sir. Thank you, sir. I think I'll pass.
You're welcome.
So in the case of multiple classifiers like P53, MMRD, and this thing, pole, is sequencing recommended routinely or in select situations only? Multi-mutated cancers. Actually, Dr. Aditi would have been good to take this question, but she left the meeting.
The multi-classifiers
Aditi, are you there? Sorry, will you take the question, sir?
If Aditi is there, let her take because she is more familiar with it.
She told she's available here, sir. I'm still trying to contact. Miss Aditi, are you there? Some signal issue. She's traveling back to Chennai, actually. Okay, fine, no issue. Sir, she is not available. She has some signal issue, not able to log in, it seems.
Multi-classifiers are generally very low, small percentage only.
Okay, sir.
And you have seen that there is a pathway of doing from top to bottom, which should come first. So that basically says that which has priority over the other thing. So if you have pole mutation, if you have a mutation down there, it has not much significance. So you have seen that MMRD is on a higher level than P53. So, so the priority will be, it is more like MMRD, it is likely to do better.
Okay, sir.
This slide shows this thing that once they are MMR deficient, so like sir said, there is a sequence of doing this thing, and the moment they are only mutated, then other things don't matter.
Yeah, that's what. Okay.
They are MMR deficient, then the next thing doesn't matter. So that's why the order is kept like that. You start with poly, The polymutated, then that's over, that is gone.
You need not test for the next two things,
Yeah,
okay?
It may not have any implications. So these problems will come when you are doing a panel testing. You are not doing a sequential testing, you are doing a panel testing, so you're going to get all the reports.
That's
So then if you are MMR deficient, then that's all. Okay, over. If you are MMR proficient, then only you go to the P53 testing.
yes.
So if you follow that order, then this multi thing would not matter much.
Okay.
But there will be 1 or 2% patients who will have this multiple
Yeah.
things. So that is why this data again is available, which shows that if you are MMR deficient with P53 mutation, you still do well.
Okay.
You go to the next slide. So this is showing that some small subgroup of patients who are polymutated with P53 abnormality, they do as well as any polymutated.
Okay.
So that is the, if you see the survival curves
Yes.
on the bottom left. Okay. So these are small subgroups which have this, but again, the poly is scoring over.
So
the
poly scores more than P53 and MMRD.
This is the evidence.
And
for
MMRD scores more than P53.
More than
That's what is the take home
That is
message
the
for the
take-home
audience.
message from
Okay. So the next question, what are the methods for testing for poly, P53 and MMR? Again, I think this is again question for Miss Aditi actually. What about turnaround time, sensitivity? It will be difficult to answer by non-lab person. We'll move to the next question. How many markers need to be mutated on immunohistochemistry analysis for a patient with carcinoma endometrium to be termed as MMR deficient? Again, Miss Aditi, right? Pampa? Srinivas, any idea about this? Just one is enough. Okay, so one deficiency is enough for us. And what's the minimum number of markers to be tested for MMRD? How should we interpret reports?
The minimum to be done is MS6 and PMS2.
Okay, sir.
Usually 4 are done, but minimum is 2.
Okay. Okay, there's one more question, sir, here. Very interesting. When should we advise for testing for Lynch syndrome if you find that they are MMR deficient tumors?
When these mutations are there, we suggest them to have counseling, and you have to know whether the family history is there, and then based on all these things, we recommend germline testing. The situation will be if MLH1 is absent, then you have to counter check with other pathways, BRAF mutation, and if that is not there, and then you say that this is not, you don't have to go that pathway for familial cancer.
So other than family history, do we have any other clinical marker to suggest that this may be associated with Lynch syndrome?
Young patients, young and thin patients.
Young patient?
Maybe. Young and non-fatty patient, you know that younger patients with endometrial are generally fattier and high BMI patients. Then high BMI patients are less likely to have, these are just some clinical parameters. To some
Dr. Pradeep, would like to say something? Our surgical oncologist.
Patients, the family history of any Lynch syndrome associated tumors, like if they're having the colorectal malignancy in their family members, and especially if they age less than 50 years. So other, or else if it is more than 50 years, other Lynch syndrome related cancer, if it is there, then we can move ahead and doing such as this. There is a criteria sets for the Amsterdam criteria is that it will be very helpful to slightly find out the family to have a Lynch syndrome.
Okay, thank you, Dr. Pradeep. I had read somewhere that if the tumor is predominantly in the lower segment, Dr. Arpita would like to talk about it. We suspect that it may be associated with Lynch syndrome, with other clinical factors put in. The tumor itself, if it is more in the isthmic area or in the lower part of the, Dr. Arpita?
The retrospective studies are only there, where the Lynch syndrome patients, it's a tumor extension is predominantly available. Tumor primarily in
the lower segment.
We say most likely to be Lynch.
Yeah, thank you.
And the uterine cancer can be a primary tumor. In such patients, you can test. Even though in the absence of.
Thank you. Is it possible to predict the molecular profile like pole mutation status based on clinical profile? Anybody, Dr. Prashant?
So So it's not actually, that's why all these testings have come. It's not so easy. There are some things which are manifested for each of these profiles. There are some characteristics which seem to be there.
Yeah.
But nothing very definite or the thing. In fact, the polymutated tumors tend to have adverse molecular, adverse pathological features. They tend to have higher grade disease, things like that. So that's why they look more aggressive tumors, but on testing they
Exactly, yeah. Dr. Lata?
Should we take like this? I mean, we all know that endometrioid type of tumors are more associated with obesity, hypertension, diabetes. Can we think of correlating those with pol mutation? I mean,
No, ma'am, that will be correlated with NSMP. No specific molecular profile will be that group of patients who are like high BMI, where we expect them to be ER/PR positive tumors.
Yeah.
There are some suggestions that we could go here, but
But NSMP tumors will be higher grade, right?
No, they are low grade, confined to the uterus, ER/PR positive. NSMP tumors, the characteristics described is that for them. Pol E can be high grade. That is why they say testing for Pol E is most beneficial in high grade. Otherwise, if it is high grade, generally what we tend, if it's endometrioid grade 3, we will go for EBRT and brachy also, right? And there is substantial LVSI.
Finally, we are going to do that depending on the stage. But pol mutation maybe in the long run will tell you how they fare. Even if they are high grade tumors, pol mutated, they have a better prognosis than those who are PGK3.
Okay.
So that way I'm
saying. I have one more question here, Dr. Prashant or anybody. Does it change staging itself? Indranil put up the staging of cancers. Okay, we have staged it according to them. Then once you get the histopathological report, you have got one particular stage. Let's assume she is stage 2B. What is stage 2B? Anybody? The people who are sitting there. Substantial lymphovascular space invasion, which is confined to the uterus. Okay, it is not gone beyond the uterus. Obviously, it is stage 2. That is the scenario. And then we send the testing for how does it affect? You have done poly and you have done immunohistochemistry for P53 and MSI, microsatellite instability. Will it change the stage now? We have labeled her as 2B depending on the...
Currently it doesn't, but who knows what FIGO or...
No, it changes. Yes, it is come up already. Arpita, will take the question? No, I'll tell it. Fine. Okay, I think in any uterus confined disease, if it is mutated, ultra mutated, it automatically becomes stage 1A. Even 2B, if it is polymutated, it becomes 1A. And if it is 1B, that is your biometrial invasion is more than 50%, and she's P53 positive, she'll automatically become stage 2C. Because aggressive tumor anyway. Okay, so that is how this even upstaging, downstaging can happen depending upon your... See, the whole idea is if you do not have molecular profile, when do we not give any treatment? If it is stage 1A, low grade tumor, no LVSI as usual, right? Well differentiated tumors. Okay. So everything, if pol is ultra mutated, then everything shifts on to that particular stage, where we don't need to give any further treatment. That's what is the recommendation, right? If pol is ultra mutated, stage 1 and 2 will escape any kind of adjuvant therapy. Stage 1 and 2 alone, madam. Yes, ma'am. Only in stage 1 and 2, irrespective of any stage you get before molecular profile, once a molecular profile comes and it is pol ultra mutated, it will go to stage 1A, right? That is what is given in one of the papers, but recommendations, I'm not sure. Is it come in recommendations? Isha? It is included in the FIGO paper itself. Okay, so it is there in the paper itself.
Maybe
yes, sir.
They may include their molecular classification into the staging of the...
Possible. Right now, it is not widely available, so they're not included. So as Dr. Prashant rightly said, nothing is permanent. It will keep on changing. Look at the staging itself. How many times it's changed in the last 2 decades, right? So more and more information keeps pouring in. More and more changes are going to occur in the way we're going to manage these patients. Otherwise, imagine we would have never thought of not treating somebody with stage 2B disease. Now, if they turn out to be ultra mutated, we'll obviously won't give them any treatment. So it's making major difference in the management of these patients.
Many more things are yet to come, not just the pol mutations and these things. Somewhere metabolites down the lane will come and we don't know what all it will change later. There are already a lot of studies coming up on that. So we really don't.
Dr. Prashant?
No, this is what we are talking about, right? So the polymutated endometrial cancer is very deceptive because generally when you see a lot of mutations in a cancer, you expect it to do really badly actually. But polymutation cancer actually does well. So that's why this.
See, this is a lovely quote given there. It's a sheep in the wolf's clothing. Because if your histopathology shows so many adverse factors here, but if poly is ultramutated, then they all are like just a mask over there. That's all for us. There's another question here. A 38-year-old lady with stage 1B CA endometrium grade 2, no LVSI, but more than 50% myometrial invasion. Okay, on IHC, there is loss of expression of MLH1 and PMS2, while MSH6 and MSH2 were intact. P53 showed a complete loss of expression. Pol E testing was not mutated by NGS. So what will be in this scenario, should the patient be classified as MMRD or P53 mutant? I think we discussed already. What takes precedence over here is MMRD actually. Okay. And what are the abnormal P53 immunohistochemical patterns in endometrial cancer? Our pathologist, Dr. Srinivas, Dr. Pampa.
P53 is either it is mutated, where it is totally lost.
Yes.
And or we have the wild type where it is not, and the other one is where it is total expression.
Okay.
Like totally it shows, so that is also actually a common mutation only. So either it is null or all.
Yeah.
Null or all, that is mutant from.
Okay.
And the wild type is heterogeneous.
Exactly. Yeah. And I have one more question.
All or none. It's mutant from. Either no cells or
all the cells. Yeah, exactly.
Then it is a mutant form. No. The expression is all or none. That means either all the cells should show or none of the cells should show. That means it's mutant.
Okay.
And heterogeneous, if it is here and there, is wild type expression. No, none of no staining will be seen. There are two types of cells. We know that. I mean,
we have used the stain, madam, immunohistochemistry stain. Come in front and speak, no? All? Okay,
so
fine.
normally when the P53 is mutated, it is not functional. It's not functional. Then protein gets misfolded. And
yes.
Because of that, the expression is more than usual. So when you see a lot of expression in IHC pathologists will call it P53 positive. But P53 positive in IHC actually means that P53 is mutated.
Exactly.
Okay. So that's how you have to interpret it. So P53 positive in IHC means P53 mutated. And if the P53 is totally absent, nothing is there. That also means P53 is mutated. Totally non-functional protein, nothing is coming.
It is wild type, yeah. I think that's a pretty clear thing now. If you do immunohistochemistry for P53, if the whole slide, all the cells in the slides take up the stain, then also it is mutated. And if none of the cells take up the stain, then also it is mutated. If it is patchy, that's the word we use, patchy kind of staining, then it will be wild type of P53, which is of no significance for us, except for one point what Dr. Prashant told. Prashant, what is a drug which is good for wild type of P53? Which is used multiple myeloma drug, right?
It's currently approved
for multiple myeloma. Okay, fine. I had one more question for a pathologist. Is there any immunohistochemical marker which can be correlated with poly testing? For example, surrogate marker for poly testing.
On IHC, I am not aware of that.
Anybody? Nothing is available as of now. I think there was one study where they saw, I think beta-catenin was tested. I'm not very sure about this. Can anybody throw some light? Dr. Francis, are you aware of anything which can be used as a surrogate for poly testing? In using IHC? Is there? Dr. Francis?
No, there is no. I am not aware of anything like that.
So any idea about this beta-catenin testing, sir? In immunohistochemistry?
Beta-catenin, that is there, but it is not connected to pol mutation.
Okay.
That's a different.
So as of now,
we
have to test for molecular. NGS only has to be used for
yeah.
poly. Okay. Thank you.
Yeah.
Yeah.
For
Yes.
Sanger sequencing. So,
Okay, go to the next question. I think that's all. Any questions from the audience? There was one on the chat box. I'll just check that. On money, yeah. The question is, how many percentage of MMR deficiency is additionally diagnosed by Sanger or PCR that are not diagnosed by immunohistochemistry? I think Dr. Saditi told.
Patients are only to do, or you can just do IHC.
Okay.
Because IHC picks up more than 90% of
Okay. So IHC picks up more than 90% of whatever MMRD. So current recommendation is to do only immunohistochemistry for that particular mutation. Okay. I think that's it. Any other questions? Okay, Sharma. Dr. Sharma is there. Dr. Sharma? Can you hear me? She's our radiation oncologist. Okay. So that's it from our side. Francis sir, thank you so much.
thank you.
It was really nice having you. I really wish you were here with us in person so that we could have discussed more. It's very difficult in virtual format for us actually. Thank you. And thank you, Aditi, if you are still logged in. Thank you so much for telling us the molecular profile of endometrial cancer. I think Indranil did a good job to start the whole program. He tried to, I think for PGs, that will be the most important thing probably as of now. And Dr. Prashant, of course, he'll always try to simplify something which is not simple at all for me. Actually, like, any questions we have, he really makes it easy for us to understand. He is an integral part of our multidisciplinary team which treats cancers in JIPMA. Thank you so much, Prashant. Now, can I call upon Mary Madam to hand over a memento to Indranil first? Padma Madam, Irkingla. I didn't see you. Indranil, please come. Somebody take a picture, ma. Kartika. Ma'am, here. Come on the stage only. I think we'll log off, sir. Thank you so much, Francis, sir. I will hand over your memento to Dr. Sharma, and I hope you get it sometime. Thank you, sir.
Thank you.
Yes, sir.
Thank you for invitation.
Yeah, thank you, sir.
Thank you for the nice program.
I think we'll log off. Thank you, sir.